as I was saying just a minute back, that he is Indian at heart, and it was such a pleasure working with him when he was in Medanta for a very short period of time. And then he went back to where as I said, his heart belongs to Delhi or India, but his mind was always in England. And I guess that's where he does probably the best. He is a consultant nephrologist and lead transplant a nephrologist at the Epsom and the St. Heliers University Hospital in London. He is a senior lecturer at the St. George's University, London. He has a tremendous interest in research, and he, during his stay at Medanta itself, talked about a lot of these things. But then in India, you get merged into clinical medicine so intensely that you hardly get time to do any research. But I think his intellectual thought process was very, very inspiring to all of us here. He is also the medical director of the S.W. Thames Institute of Research at the St. Heliers University Hospital. And I can tell you that during his stay in India, he endeared himself with his intellectual thought process and also with his analytical capabilities. And this was during his day-to-day interactions at our place, as well as during the lectures which he gave at multiple places, and even at the Indian Society of Nephrology, Organ Transplantation, and other forums. Whenever he got an opportunity to speak. And it's a pleasure to welcome Phanish
Thank
at
you.
the immunological evaluation of kidney methodologies which are existing. Phanish, I'm still driving. I'll hope that once I reach home, I'll rejoin and listen to part of the lecture. I would miss
No
some,
problem.
but okay, all the best.
Thank you. Thank you for that introduction.
Thank you for
very much.
Accepting the invitation.
No problem. Thank you very much. Now, I've started sharing my screen. Can you all see it?
Yes, sir.
Yes.
Okay, so I will try and put that on a slideshow and see if that still works. Does that still work? Can you see the screen? All right.
Yes.
Okay, excellent. Okay. Good afternoon to me, well, here, or good evening, everyone. Dr. K, thank you for that introduction. I really appreciate it. So no, it was a good time in Medanta. It gave me a whole different perspective of when you work in different healthcare systems, the challenges involved, and what we face in one place to the other place. The medicine remains the same, but the structural challenges and the societal challenges and various other. It was really good to see and work, and I came back with a good deal of experience of different nature, I must admit. And thank you for asking me to talk. So what I'm hoping to do in the next 40 minutes or so is to take you guys through how do we assess the immunological risk of a kidney transplant recipient. So what are the things in our mind, what we are trying to achieve, both in terms of the graft outcome and the patient outcome? What are the techniques that are available, and how do you think we should use it? There are so many tools one can use. So it's a question of how we use that in the context of a given patient, rather than going by a dogma of a particular protocol or a guideline. For example, we use the guidelines, but how do we fit that into a day-to-day patient care? So I'm hoping to achieve that in the next 40 minutes or so. So just as a formality, I have nothing to disclose. And I can also confirm that this meeting is COVID-proof because we are around 5,000 miles apart. So it's very unlikely we will transmit COVID in that distance. and I don't think COVID is transmitted through a network of computers, but I'm pretty sure that conspiracy theory is going around some social media as well. So it is a COVID-proof meeting. So moving on, I just put this X-ray because nothing, no meeting or no discussion these days can go away without talking about COVID. And when Dr. Kher phoned me to say, can you give a talk? I must admit I was relieved he wasn't asking me to talk about COVID because talking about COVID in the last 1 year, we have done so much on it. So I was really looking forward to talking about something other than COVID. So I'm very pleased when you said you are going to talk about HLA antibodies and transplantation, not COVID. So just to show, this was an X-ray of our kidney transplant recipient with COVID pneumonia. As you can see, a typical appearances. So this guy thankfully survived, and this is an X-ray about 2 months later. Cleared pretty well. So he received the current standard of care of remdesivir, dexamethasone, and we had to give him tocilizumab in addition to CPAP and some modulation of immunosuppression. So that's all I'm going to talk about COVID. Let's move on. So some of the things I'm going to tell is clearly more applicable to what we practice in the UK. And you need to look at how the transplantation occurs in India and which bits of these are more applicable to you as opposed to what we do here. Just to give a snapshot of kidney transplantation in the UK. So we obviously have, like everywhere else, a deceased donor and the living donor transplantation. But unlike what you may see in India, we have a significant proportion of kidney transplants that are deceased donor uh, or what you call cadaveric donors. So we have removed that terminology now. We call them exclusively deceased donor kidney transplantation. And in the deceased donor kidney transplantation, there are two types of deceased donor: your standard cadaver donor or a donation after brainstem death. So these are the kidney donors whose brain is dead but heart is beating. So these are heart beating donors. And the second group of deceased donors are DCD, or a donation after cardiac death. We don't do any uncontrolled DCDs in the UK. We are predominantly controlled DCD. I won't go into details of that, but certainly the DCD, or a non-heart beating transplantation proportion, is progressively and steadily rising. This slide is slightly old, and I would say now maybe the DBD transplantation and DCD transplantation, the DCD is around maybe 20-25%, and the DBD has remained more or less static over the last 10 or 20 years. And that is to do with a lot of work the country has put in retrieval teams and specialist nurses in organ donation, et cetera, in different hospitals. Then moving on to living donor, we obviously have a directed living donation, which can be living related kidney donor or a living unrelated kidney donor, including we do a large number of, I will explain that in my subsequent slides. We have a significant number of what you call there as a swap or a kidney swap, and we call it as a national kidney sharing scheme. The previous name was paired exchange, when the two pairs exchange the kidneys across HLA or a ABO incompatibility, but now we call it as a kidney sharing scheme. And we also have an increasing number of non-directed altruistic kidney donors. What I mean by that is these are citizens in the country who simply come forward to donate a kidney to somebody whom they don't know. So these are not directed to anyone, and they will never come to know whom they are donating to. They basically undergo all the donor workup as you would do otherwise. And once they are deemed suitable to donate a kidney, their kidney is donated to the national pool to be matched to a recipient on a deceased donor list. So that number is increasing. I think in the last few years, around 150 altruistic non-directed transplants have been done, which is an interesting ethical discussion altogether. And then obviously we have ABO and HLA incompatible transplants. So I must say here that we are doing lesser and lesser blood group incompatible or HLA incompatible transplants in the UK because of highly successful kidney sharing scheme, which means we are almost always we are able to get a compatible kidney for a given recipient rather than going through an incompatible transplant and subjecting the patient to immunoadsorption or plasmapheresis to remove the antibodies, or desensitization program, or rituximab, or augmented immunosuppression, which tend to have slightly less than favorable outcomes in those recipients. So this is just to say what do we do in a transplant program? You know, in a if someone is on a list to receive a kidney transplant, we do tests to assess how much they are sensitized. And what I mean by that is what amount or what number of HLA antibodies these recipients have. And we want to know what are the chances of this particular recipient getting a matching kidney in a national disease donor transplant program. And what we want to do is to avoid any donors with unacceptable antigens. And what I mean by that is any HLA antigen against which the recipient has a HLA antibody, and what's called as donor specific anti-HLA antibody. So when you measure an HLA antibody, it doesn't come with the tag of this is donor specific. You basically measure a HLA antibody, define its specificities to see what HLA antibody it is. Then you want to look at the HLA type of the donor to see if this particular antibody is against any particular HLA antigen that the donor is carrying, if that makes sense. And then you label it a donor specific antibody. I'll put this website here for those who are interested. It's a UK national website called ODT. It's a very open platform. It has all the details of all the transplant centers in the UK, number of people on the list, number of transplantations performed, 1-year graft survival, 5-year graft survival, patient survival, comparison between the centers. It's all put out in a very open and transparent manner. And it also describes how we allocate deceased donor organs in the UK. The system has changed recently, but it's for those who are interested in deceased donor transplantation, how should a local or a regional or a national system should be developed to allocate the kidneys in a fair and equitable manner, and what are the factors you want to take into account when you are designing a tool or an equation for organ allocation or a computerized algorithm. It's a good one to look at if anyone is interested to move in that direction in the future. So I do recommend when you have a time, it's accessible to anybody without requiring any subscription or passwords. It's an open platform. And we also look at a test to assess what is the immunological risk for a particular donor recipient base. So what I'm trying to do, explain to you is that we have a slightly different way of looking at for deceased donor and living donor kidney transplantation in terms of what we do. So this is a slide just to show an example slide from that ODT website I was talking about. So on the x-axis here, it lists every single transplant center in the UK. We come under St. George's. For example, it tells you the number of people active on a kidney transplant list. This is for a deceased donor transplantation as of that particular date. So this changes based on the data. We are all bound or required to submit our data. All the centers have to submit our data to a national transplant registry, and the data is uploaded into this website so that we all can look at what's the strength or a size of our program year on year. And this slide, for example, shows the number of kidney transplants that we have performed over a period of 1 year. In this case, April 2019 to March 2020, we did 159. So that's St. George's, but you can see some centers do more, some less. It's all not meant to be a competition or trying to say we are better than someone else. It's essentially an open, transparent way of sharing the data so that we all learn from how we do things with each other and improve. This is another graph quickly to show you from the similar, that's the same ODT website. Each alphabet represents a transplant center. The line in the middle is a national rate for 5-year graft survival, which as you can see is around 85% for a deceased donor kidney transplant, but some centers on the top do pretty well with a 5-year survival of about 90%. And similarly, if you look at the patient survival, you can compare patient survivals of each transplant centers in the UK. And then we can talk to each other and perhaps learn if someone is doing things slightly differently to what we do. So there is a learning environment for us to look at each other practices and improve. So that's the objective of this platform. So moving on, If I'm going very fast, please do interrupt. Is that okay so far? Can you all hear properly?
Yes,
Yes, sir.
I think I can hear you. So
You can
I
hear.
would
Okay.
guess that most people should be able to hear you. It's been
All
good,
right. All right.
and
Yeah.
you are true Englishman going slow, which is okay.
That, yeah, no, I was worried that I'll go too fast. Sometimes
No,
that's
no,
the difficulty. As long as people can
yeah,
hear, that's
yes,
great. Thank you. So, okay, so I will move on. So then we have the next few slides. I'm going to describe what technologies are available. Again, I would like to emphasize here, it's not that you have to use one particular technology. The key thing is you use what is available for your particular center, where your tissue typing and immunogenetics laboratory is comfortable with, and how you interact with them and how you can establish a relation between your clinical group, the transplant clinical team, and your tissue typing laboratory team. And neither of these are like you do this, I do this, so that must be right, that must be wrong. So all these tools are available. It's a question of establishing what works for you and what is a bare minimum standard you want to aspire to when you do a kidney transplantation. So historically, since the Tarasaki and Patel described, and I strongly recommend you should try and read that original paper of Tarasaki and Patel on CDC crossmatch, which revolutionized kidney transplantation. And that was, I think, about 40 years ago, if I'm right. So they described complement-dependent cytotoxicity, and that remained a gold standard for performing a cross-match. And essentially what cross-match is you're trying to understand if a given recipient has got HLA antibodies against a donor kidney. So essentially you're trying to see, does this recipient have HLA antibodies against donor HLA antigens? If they have, what is the amount? How much they have? Is it a very small number or a big number? And if they have, are they going to bind to the donor HLA antigen or donor kidney? And if they bind, are they going to activate the complement? Because whenever there is an antigen antibody reaction, you do activate complement. And the tissue damage or endothelial damage or a vascular damage occurs when there is a complement activation. So if you just bind and don't activate complement, you don't get tissue damage. So these are the questions in your mind when you're trying to interrogate how compatible a recipient is to the donor. So it all started off with this complement-dependent cytotoxicity. So as I explained earlier, activation of complement upon an antigen-antibody interaction. Then it moved on to far more sensitive cross-match technique called flow cytometry cross-match, which we use quite exclusively. In our South London, so St. George's and Guy's, we don't use CDC much. We use predominantly flow cytometry. That doesn't mean CDC is not important. I'm simply saying what we use here. So these are cell-based assays. And again, I will describe a bit more with your next slide. So these techniques require cells. So you do need donor cells, which have HLA antigens, class 1 and class 2, class 1 being A, B, C, and class 2 being DR, DP, DQ. And we need recipient serum, which potentially have HLA antibodies, and you're going to mix the donor cells with the recipient serum in a different platform, whether it is CDC platform or a flow cytometry platform, to look at binding and complement activation. That's your cell-based assay. Then we increasingly are using all over the world solid phase assays. So essentially what solid phase platforms mean is that you've got either a plates with wells in it in which you coat an antigen or an antibody, or you have commercially available beads that are coated with HLA antigens. So basically you've got polystyrene beads, and that can be coated with HLA antigens of different types. And then when mixed with the recipient serum, which potentially has HLA antibodies, binding occurs, and that can be detected via various detection mechanisms. So that's a technique called Luminex, which is used very extensively nowadays across the world for kidney transplantation. But a similar beads, somebody is scribbling on the slide. Similarly, the same beads which have HLA antigens can be put through flow cytometer. just like you can put it through Luminex. So again, I strongly suggest that, students out there, if you're able to, please go to the laboratory. Try and go to the laboratory, try and speak to the technicians there, try and speak to the scientists there, and understand, you need to see the machine and watch how they do it. And that's the best way to understand how these assays are done, what are the limitations, and why sometimes the lab finds it difficult to give you an yes and no answer. When the clinicians say, why don't you tell me? Because these techniques are not that straightforward. And there are gray areas and issues that need to deal with, which makes the clear answer difficult. So this is a pictorial representation of CDC. So as you can see here, it's a sort of either a 40 or a 96 well plate. So these are sort of plates with little wells in them. And you essentially put donor lymphocytes in it. So the donor lymphocytes are either derived from peripheral blood. In the case of a living donor, for example, you take the blood and you isolate the lymphocytes. You can separate them into B and T lymphocytes based on the cell surface antigens. For example, if you use CD3, you would take out the T lymphocytes. And if you use CD19 or CD20, you would take out the B lymphocytes. So you can sort them or separate them and put them in these wells. And then you mix that with patient serum, which may have HLA antibodies. And then as you can see here, this is a cell with all these green circles there. That's your HLA antigen. That's your HLA antibody. And then you add rabbit complement as a source of complement. And then you look under microscope. You can do two different things. Either you can put two dyes, one green dye and one red dye. They have got names, which I forget. The green dye is basically taken on by every cell, living or dead. But the red dye is only taken up by cells whose membrane is damaged, so i.e. dead cells. So then you can count the number of red cells and express that as a proportion of total number of cells. And usually more than 20% cell death is classed as a positive CDC cross match, and it's graded 20 to 40, 40 to 60, 60 to 80, more than 80%. And each laboratory will have a slightly a different technique to try and establish what's positive and how do they grade the positivity of a particular reaction. And this is another cartoon. You can get it from Google of CDC cross match again, but this time looking at cell death rather than color dye, the red and green that I showed you in the previous slide. So you've got donor lymphocytes with various colored HLA antigens on the surface. Clearly, it's a picture. You don't expect this in vivo. Human cells don't have colors like that, unfortunately. And the recipient serum will have or may have donor-specific HLA antibodies. And then you mix it up and add complement. If there is no donor-specific HLA antibody, you don't have any cell death here. All cells look nice and happy. But you have got donor-specific HLA antibodies. It will bind to HLA antigens on these cells. And upon activation of complement, it will cause cell lysis. And as I said before, if more than 20% cells die, either as in cell lysis or as in number of red cells, then you class it as a positive CDC cross match. I will now move on to the flow cytometry, which is again very similar principle, but just a different platform. It's a different equipment and a different way of putting the cells through the cell sorter and doing the assay. So your fundamental principle is the same. You've got donor lymphocytes shown here and the recipient serum with HLA antibodies. And if there is if any of these antibodies are specific to these HLA antigens, this antibody will bind to this antigen. And then you've got a secondary antibody, which has got a fluorescent tag. Fluorescent is basically fluorophore, which will emit lights of different wavelength when hit with a laser. So when that fluorescent secondary antibody binds to it, then that will be detected by a detection system in your flow cytometer as a positive test. This is another depiction of how flow cytometer works. So you send the cells through this part of the machine, donor lymphocyte. If there is HLA antibody, it will bind to that. And then this is the detection antibody, essentially an antibody with a fluorescent tag raised against human IgG. So it's an anti-IgG detector antibody. So it will bind to that, and then you can detect as a shift on a flow cytometer. It's really difficult to explain this correctly or in a talk. I'm giving you the basic ideas, but I strongly urge that you go to the laboratory place to see how these things are done. It's really good for your training and for the future if at all anyone of you want to go down the academic route. Okay, so what is the advantage of hang on. So I'm going to move forward a bit. Okay, I'm going to move forward to this and come back to that slide. So let's talk about Luminex. So Luminex, that's how the machine looks. You probably have seen this if you've gone to the lab in various places. It's used quite extensively and also misused sometimes in terms of how we interpret it. So essentially, this technique uses small beads onto which you've got HLA antigens coated. And there are essentially commercially available beads from various companies. And there are 3 levels of bead attachment. So I want you to picture a cell with HLA antigens in your mind. So just imagine you're taking those HLA antigens out of those cells and coating them onto a synthetic bead. And that's what you're essentially doing here. The company does it for you and they sell you the beads which has got HLA antigens on their surface. Now, one group of little tubes or beads basically consist of a range of class 1 and class 2 HLA antigens on its surface. Then another batch of beads essentially behave where each bead is like a cell. For example, there will be 2 molecules derived from 2 alleles of class 1 and class 2 loci on each bead. So you should be able to say on the tube, it will be written class 1 beads, class 2 beads. So if you use those beads, you'll be able to say this particular patient has class 1 HLA antibodies, or this particular patient has a class 2 HLA antibodies. Whereas the generic beads I'm talking about, the level 1 beads, will essentially tell you are there HLA antibodies. So if you want to screen somebody to see if they've got HLA antibodies, you would use the level 1 bead. It's a screening test. It's not specific for a particular HLA antigen. It screens and tells you if a patient X has got HLA antibodies or not. Then you got the second level beads where you have a tube filled with class 1 beads and tube with class 2. Essentially, these are beads coated with class 1 and class 2 antigens, but separate. So using those beads will enable you to decide or confirm if this particular recipient has got class 1 or class 2 HLA antibodies. Then you got a level 3, which is a single antigen bead, or also called a SAB. So essentially, these are beads where one bead has one HLA antigen, and they will give you the description on a product sheet as to which one is what. So a range of HLA antigens, class 1 and class 2, A, B, C for class 1, and DRDP, DQ for class 2, will be coated on these beads, and they will be sold as a single antigen bead. So when you use this antigen, if an antibody binds to it, then you can specifically tell that particular antibody is for which HLA antigen. So just wanted to show you the slide. So why use this solid phase assay? So why they're useful is that you don't require any viable lymphocytes or complements. So essentially you can run the assay anywhere. You don't have to harvest the cells. You don't have to save the cells. You're not worried about cells dying off. So there's no requirement of viable lymphocytes. So they are very useful in terms of measuring the HLA antibodies. And they will only detect HLA specific antibodies. They don't detect any non-HLA antibodies and clinically irrelevant antibodies because your beads are only coated with HLA antigens. So only an HLA antibody can bind to HLA antigen. And it will detect non-complement fixing antibodies. Some may argue that's a disadvantage because you want to be detecting only an antibody that binds to the antigen and activates complement, because that's when the tissue damage happens. But that's another debate or a discussion. But for the purpose of this talk and your understanding, they detect non-complement fixing antibodies, unless, of course, you add complement. I mean, you can add C4D and modify a Luminex HLA antibody assay to C4D fixing antibodies. Still, I would say a bit experimental in terms of its utility in clinical practice and optimizing graft outcomes. They are very objective and partially automated, semi-quantitative. So you will be able to get a number in terms of titer of the antibodies expressed as mean fluorescence intensity, or a MFI. And they are commercially available. And all these platforms are commercially available. We don't use ELISA for detection of HLA antibodies, but I do know some centers across the world do. We do flow cytometry for a cell-based cross-match, but we don't use flow cytometry for microparticle-based PRA. But I do know some centers do use flow cytometer with beads coated with HLA antigens as a flow PRA. And we used to use that when I was in Medanta, for example. The flow PRA. There was a guy called Pranav Dorwal at that time whom I was working with or chatting to him with regards to these flow PRAs. And the Luminex technology, which we just now discussed. So this, I think we have talked about. Go and read about it. And as I said, please try and go to the lab to try and understand it a bit more. So this is the description of beads. They are tiny 5.6 micron beads coated with HLA antigens. There's high level of technicality that goes into making these beads and coating these HLA antigens onto the surface. It's a very complex thing, but has been sorted now as to make it very commercial and easily available. This is how Luminex works. So you got these beads coated with various HLA antigens shown as either green triangles or squares in this picture. So each one of that is an HLA antigen. And then you've got recipient serum, which may contain HLA antibodies. The beauty of Luminex is that each bead has got a unique dye in it. And therefore, when a laser beam excites it, it will show, or it will throw a different signal. Each bead will throw a different signal so that you can pick it up as which bead it is. And then you got, once an HLA antibody binds to the HLA antigen, you got a reporter antibody, which is a secondary anti-IgG with the reporter dye. So you have once you do that, once you mix it, put it through the Luminex machine, there is a dual beam laser. One laser will hit the bead and detect what dye it has. So it will be able to tell you this is bead number 240, for example. And if it is a single antigen bead, you will know that bead is A2, for example, or HLA-A2 or B4. And then the second beam will identify the reporter dye, which is attached to an anti-IgG immunoglobulin, which would have bound to an HLA antigen antibody complex. So using dual laser detection system, you can detect the bead and detect the antigen antibody interaction. So I think we have already described this, just to highlight again. So the first level will be a screening test to tell us if there are HLA antibodies or not. Subsequent level would be to tell us, is it class 1 or class 2? And then the single antigen bead, which tells us which specific HLA antigen the antibody is targeted to. For example, is it an HLA-A2 antibody or DR1 antibody or DQ5, etc., etc. So moving on to Luminex, I'm spending a bit more time on Luminex because that is something that's used extensively and lots of questions come up on that. It's a very highly sensitive test. Now that's where problem comes as well sometimes. You need to understand in medicine, any test that's very sensitive also tends to have more false positive results because it picks up everything. For example, PCRs are very sensitive. It will pick up a small sequence of RNA augmented, and then that may or may not be clinically relevant. So some of the antibodies that are detected on Luminex may not be clinically relevant, okay? And also it can, as I said, cause false positive results. And just for you to understand, these are the beads which are then coated with HLA antigen in the laboratory. So the coating process will vary from batch to batch. Now, the amount of HLA antigen on each bead will differ from batch to batch. And the antigen density, as it's called, again differs. And on your cell, the proteins have a three-dimensional tertiary structure, which may not be the case when you denature the proteins in vitro and put it onto the beads. So you must try and understand that they are not like a cell. They are artifactually synthesized in the lab subject to alterations in the protein, the epitopes, antigen expression sites, etc., etc. And therefore, you have to read the results carefully, bearing all these caveats in mind. And the mean fluorescence intensity that the laboratory reports doesn't always equate to the amount of antibody in the serum. It's reporting you the amount of antibody bound to the antigen. If a particular antigen is in abundant, so you may see more binding. If some antigen antibody complexes have a different affinity. So sorry about this. I will have to call you back. I'm just giving a talk. All right, no problem. Bye-bye. Sorry about that. So the mean fluorescence intensity that you see may not always equal to the amount of antibody in the serum. So although it is quantitative, we need to understand all these issues when we interpret it. So this picture tells you the various tests that are available and their ability to pick up HLA antibodies. So CDC in the right hand of your screen is the least sensitive one. So that will pick up high number or a large number of HLA antibodies. Some clinicians would say that is enough. All we want to know is HLA antibodies which are in a high amount and which will cause complement dependent cytotoxicity. If the CD is negative, I'm happy to proceed with the transplant. Why bother with all this flow cytometry and Luminex? That's an argument. But CDC will miss lower level of HLA antibodies. There's something called augmented CDC, which we don't use, and ELISA falls somewhere in the middle. Again, we don't use it. Flow cytometry we use extensively, and that will detect sort of low to moderate amount of HLA antibodies. The Luminex, particularly the Luminex single antigen bead, is highest level of sensitivity to pick up even a smallest amount of HLA antibodies in your blood. So if your Luminex assay is negative, yeah, you can confidently say that there are no HLA antibodies in that particular recipient. So moving on from that, so how should we read DSAs? You know, how should we understand what's a DSA? Once again, I want to reiterate here, the students get often confused between HLA antibodies and DSA. What we are measuring are HLA antibodies. They are donor specific if any of them is against a particular donor HLA antigen. So you cannot tell if an HLA antibody is a DSA without knowing donor HLA typing. Okay, please just to make that clear, understand that you do need a donor HLA type in front of you for you to decide if an antibody that you're detecting is a DSA. And if you give the HLA type of the donor to the laboratory, along with the recipient serum, they will do the Luminex assay. They will specify which antibodies they are, and then they will be able to tell you that this particular antibody is donor specific. Okay, so we need to know if the DSAs are current. What I mean by current is antibodies present when you at the time of a planned kidney transplantation. Historic is that these patients had HLA antibodies in the past, but they don't have it now. But there may be an immunological memory. You know, for example, if it is second transplant and the second transplant has the same HLA antigen as the first transplant, and if the patient had a DSA for the first transplant in the past, but now they have disappeared, they will still have memory cells in their system. So upon exposure to the second kidney with the same antigen, they can mount a reaction and a rejection. So that's called a historic DSA. So we do need to know when you're transplanting people second time and third time, if they're expressing same antigen as a previous transplant, and was there ever a DSA against that particular HLA antigen. We need to understand, is this DSA single or multiple? Or i.e. is the DSA against a single HLA antigen or multiple HLA antigens? And we need to understand how strong is the DSA? What is the strength of DSA, i.e. the mean fluorescence intensity? Based on these, various centers use various stratification measures for the recipients. We use a bit more simpler actually, but this is one suggested. Please do not take these numbers as an absolute. For example, MFI of less than 5,000 is an arbitrary number. It has to be decided in your individual laboratories to understand what level of DSA is likely to make cross-match positive flow cytometry and CDC. It's very much a work between the transplant center and the tissue typing immunogenetics laboratories. So for example, if someone has no DSAs, current or historic, flow cytometry or a CDC cross-match negative. We use flow cytometry cross-match almost exclusively. Uh, if I have a time, I will explain what the CRF is, but for your purposes, see it as PRA or a panel reactive antibodies. We do it slightly differently, and we call it calculated reaction frequency based on virtual antibody testing and matching. But for your purposes, call it PRA or a panel reactivity, panel reactive antibodies. An intermediate immunological risk could be somebody who had a historic DSA or has a bit more HLA antibodies or has a very low level DSA and cross-match negative. And high immunological risk, you could call someone with a high level of DSA above 5,000, and their cross-match or a flow cytometry at an MFI of 5,000 is usually positive, not always, but usually positive. And if the DSA titer or MFI is far higher than that, like more than 10,000, cross-match is usually positive, the flow cytometry and CDC. If any of the cross-match is positive, we call it, or we should call it, HLA incompatible kidney transplantation. Okay, so I think I'm going to skip that. I think we already talked about this. I will move on. So I often get asked about this, a question about this. You have a DSA, but the cross match is negative. So what does that mean? Again, as we discussed, that basically means that the DSAs that are present are at low level, and the cross match technique you're using only detects high level DSA. For example, if you have a low level DSA, your CDC is likely to be negative. And if you've got very low level DSA, the flow cytometric cross match is likely to be negative. Arbitrarily, this gets defined as less than 5,000 MFI of a DSA as a weak DSA. Some units use less than 3,000, some use less than 2,000. So just it depends. And a 5 to 10,000 as an intermediate strength DSA, and more than 10,000 as definitely strong DSA. It's very likely that these two groups cross match is likely to be positive. It's very unlikely that when you have a DSA above this level, your cross match will be negative. In particular, the flow cytometry cross match. CDC may be negative, but flow cytometry cross match is likely to be positive. So what do we do here, or what is recommended if you have a DSA at a low level, but the cross match is negative? We still put them through kidney sharing scheme to try and find a kidney against which they don't have a DSA. And we have a very high success rate nationally of finding a matching kidney. They usually wait for about 3 to 6 months, but that's not a big issue here because dialysis and transplantation and everything else is provided free of cost under National Health Service. So the cost isn't an issue often. So we put them into kidney sharing scheme and then wait for a matching kidney. And if you can't do that, which in many parts of the world, people need transplantation soon, they can't have long-term dialysis for several months, then you could proceed with the transplant when the cross match is negative and you've got a low-level DSA. Either you can go with the lymphocyte depleting antibody. I do know you guys use lots of ATG. We don't use as much. Or at Guy's Hospital here, Campath or alemtuzumab, which is an anti-CD52 lymphocyte depleting antibody, is used quite extensively. And again in West London as well. So some of the London centers use Campath. When you want to transplant against a DSA barrier, if cross-match is negative, we have ATG in our protocol. But you can still also proceed with standard basiliximab, TAC-MMF PRED, and reserve things like plasma exchange, ATG, if an AMR or a T-cell vascular rejection develops. And you will have to monitor some DSAs post-transplant. So if you've got a moderate DSA, again, we would go for a kidney sharing scheme. But if you can't do that and cross-match is negative, you go ahead with transplantation with a lymphocyte depleting antibody and triple immunosuppression. It's not always necessary to do desensitization if there is a low-level DSA and a flow cross-match is negative. I know that is debatable, but that's my feeling, and that's the feeling of many authorities. But you've got a very high titer DSA, we again go to kidney sharing scheme. That's our practice here. Risk of AMR or acute antibody mediated rejection remains quite high. And these patients will need depleting antibody. And if their cross match is negative, we call it HLA incompatible transplantation. And these patients usually have DSA levels of more than 5,000 MFI, and they will need desensitization with double filtration plasmapheresis Either you can do cascade plasmapheresis or a membrane plasmapheresis. We almost exclusively use membrane plasmapheresis, but some centers do use cascade, done by hematology centers. And then use either rituximab, they will need IVIG, various cocktail of drugs you can use to try and desensitize them down to cross-match negativity. Again, just to reiterate, presence of DSA does not necessarily mean you need to put the patients through DFPP or a plasma exchange and rituximab, as long as the flow cross-match is negative. So if the flow cross-match is negative, you could argue that you can transplant them with a depleting antibody induction and a careful monitoring of kidney function and DSA post-transplantation. Okay. I don't think I need to tell you guys these. You guys know ATG much more than me, use it a lot, so I will skip that. Campath is anti-CD52. It is used when there is transplantation in the presence of a DSA in some of the centers in the UK. It's quite simple to administer, 230 milligram doses, subcut injection. First injection is given in theater upon release of the clamp and perfusion of the kidney. And second dose is given on day one. It's slightly age dependent. And the results are pretty good from what's been published so far. And there is this question always comes, how long you should monitor DSA and what frequently following a transplantation across a DSA barrier. I don't think we know the answer. Make up as you go along, and there will be cost implications as well. So maybe monthly for 3 months or 6 months. Some centers do more frequently. There is no clear guide as to how frequently one should monitor DSA. But what I suggest is monitor kidney functions very carefully, look for proteinuria and other indirect markers of transplant glomerulopathy in a long setting, and then do DSAs as needed rather than spending too much money on regularly doing DSA post-transplantation. So the role of long-term regular surveillance for DSA remains unclear as far as we are concerned. So we don't do it routinely, and we don't believe it is cost effective. We do it routinely if a transplantation was done across DSA barrier. We don't do it for compatible transplants. So it's published as well. You can see this is basically our simplified immunosuppression protocol. So we divide our patients as high as low. It's very simple. Anybody with second and subsequent transplants, we class them as high risk with a PRA or a CRF of more than 50%, no DSAs. Low risk, again, no DSAs, less than 50% CRF. Anybody with DSAs, we tend to put them through National Kidney Sharing Scheme. And if they don't get a match, then we discuss transplanting them, provided the cross match is negative with ATG induction. Okay, and long term, we believe in dual immunosuppression. We don't keep people on triple immunosuppression long term. So by 3 to 6 months, most of our patients are on dual immunosuppression, either tacrolimus mycophenolate or tacrolimus pred. And in large number of patients, we withdraw prednisolone on day 7 completely. And so we see fairly low rates of post-transplant diabetes of around 8%. And we also use much lesser mycophenolate than many centers do. So we see far lesser proportion of BK virus and cytomegalovirus infections because of reduction in mycophenolate dose. How much more time do I have?
So you can continue easily, sir.
Another 10 minutes?
No,
Yeah,
sir.
you can
Usually
continue. You can continue.
Yeah, but I hope people are awake because I can't see anyone. I will continue.
Yeah, yeah. You can continue. I think.
Yeah. Okay. So I think the next couple of slides are just for this particularly because I know there are lots of students out there. This is how you interpret T cell and B cell cross match. So when you do a cross match, whether it is flow cytometer or CDC, if T cell and B cell both are negative, that basically tells you that there are no DSAs to class 1 or class 2 HLA antigens, or it tells you that DSA titer is too low. There are DSAs, but the levels are too low to be detected by a CDC or a flow cytometric cross-match. In particular, CDC cross-match will miss low level of anti-HLA antibodies. Or it tells us if you're using, for example, CDC exclusively, then the CDC won't detect non-complement fixing antibodies, and therefore it will miss that. If T cell and B cell cross-match are positive, then you know that there are DSAs to class 1 or class 1 and 2. The reason I say that is class 1, class 2 is exclusively expressed on B cells. There is no class 2 on T cells. No, am I right? Am I wrong? Anyway, move on. So T cell negative, B cell positive. So we'll tell you that the DSA to class 2 or class 1 and 2, because the B cells would express both class 2 and class 1 and 2. You cannot have a situation where the T cell is positive, but B cell is negative. It usually doesn't happen. So if you see a report where T cell cross-match is positive, but B cell is negative, you just need to check with the laboratory, is there a technical error? Other way around, it can happen, the T cell negative, but B cell cross-match positive. But T cell positivity and B cell negativity is uncommon and usually a technical error. I'm just going to show a couple of reports that we get. I've blocked out patient details with that box there. I hope there is no patient identifiable things on this. I don't think. So this is a standard report we get from our tissue typing laboratory. For example, this is a donor recipient pair. FCXM stands for flow cytometric cross-match. That's the number of the test. T cell and B cell negative. It tells us about the mismatch grade of AB and DR between HLA, between donor recipient. But we also test for C mismatches, DP, DQ, and DR. But what gets reported routinely is AB and DR. It tells us about CRF, which is, as I said, for practical purposes, is same as PRA. But we do it without using cells. It's a virtual assessment of sensitization status of the patient. Peak CRF, in the sense the HLA antibody status anytime during the journey of the patient was 26%. And then we say cross-match, then the report comes as cross-match, T and B cell negative, no DSAs detected. You can go ahead as a standard risk or a low risk kidney transplantation. It's another example of a very fairly highly sensitized recipient with very high level of HLA antibodies. 87% basically tells us that this person will react to around 87% of kidney donors in terms of HLA antibody specificities. So it has both class 1 and class 2 HLA antibodies with very high level DSA, as you can see in the right column there, over 25,000 MFI. It was even higher, around 54,000 back in 2019, at which time he developed an acute AMR with thrombotic microangiopathy, which we treated with plasma exchanges, IVIG and rituximab. And that's probably the reason why there has been about half reduction in his MFI. So he had his mother as a donor. We were working them up. But among the HLA antibodies he had 2 donor-specific antibodies against HLA A1 and DQ2. So class 1 A1 antibody and class 2 DQ2 antibody, due to which his B cell cross-match was positive. His T cell was actually negative. He had a positive B cell cross-match, but very strongly positive. The just positive B cell cross-match may not be relevant, but a fairly strongly positive B cell cross-match as per our laboratory, based on which advice given to us was that we should go down the route of kidney sharing scheme, which we did. And we found a matching donor for this recipient. And as you can see with this matching donor from another center in a kidney sharing scheme, the mismatch is 2-0, but T cell and B cell both cross-match are negative. So we went ahead and did a transplant for this man. Because there were no DSAs, we decided to go ahead with standard basiliximab induction with tacrolimus mycophenolate PRED, and he's doing extremely well with no rejections. Graft function is excellent so far. So it's quite important to distinguish HLA antibodies from donor-specific antibodies. So the presence of HLA antibodies by itself doesn't mean you need to do lots of things like desensitization and aggressive immunosuppression. As long as you exclude donor-specific antibodies carefully and the cross-match is negative, you can proceed with. And again, I want you to read another line here. After autoreactivity has been accounted for. This is quite important. Sometimes the cross-match we are talking about is alloreactivity. What I mean by that, we are looking at recipient serum with another individual's donor cells. So sometimes people react to their own cells, an autoimmunity or an auto cross-match. So sometimes the test comes positive. You don't know, is it due to auto antibodies binding to the lymphocytes, or is it allo antibodies binding to the lymphocytes? And often this happens with B cells. It's quite common to see auto cross-match positivity with B lymphocytes, very uncommon with T lymphocytes. So they do, when the such a result comes, the laboratory automatically, they do an auto cross-match. Basically, that means they take recipient lymphocytes and recipient serum, mix the recipient serum with recipient lymphocytes, rather than recipient serum with donor lymphocytes. And if they see a positive test of similar amount, that means it's an auto cross-match positivity rather than allo. And also they try and distinguish IgM and IgG. If you add something called DTT, it breaks IgM, and then it will only detect IgG anti-HLA antibodies. IgM antibodies are not very relevant in clinical transplantation. So I've got a couple of cases. I've already discussed a couple of those cases that we have transplanted recently. Another one here, so brother wants to give a kidney to a woman, and these are the tissue types on the top. T cell and B cell cross match is negative, but the flow cytometric cross match is positive. T cell negative, B cell positive. So what does that mean? That basically tells you that this person probably has got class 2 DSAs, but they are not high enough. The amount is not high enough to cause T cell positivity, or this is false positive B cell cross match, and we don't have to worry about it because the T cell cross match is negative. So these are the interpretations of that particular result. Either the patient has very low level DSA and therefore a B cell flow cross match is positive, but T cell is negative. Or there are DSAs which are non-complement fixing. As you may remember, the CDC will only detect complement fixing antibodies. It doesn't detect non-complement fixing antibodies. Whereas flow cytometry will detect any binding antibody because there's no complement involved on a routine flow cytometer. Or there are non-HLA antibodies or autoantibodies. So what do you do next? So then you do a solid phase Luminex assay. If there is no DSA on Luminex, we could ignore the flow cytometry B cell cross-match result and proceed with transplantation. And the false positive B cell cross-match is more common, as I've said a few times now, just to sort of reiterate so that it gets into your minds. It's more common compared to T cell cross-match. Another patient being assessed for transplant. Again, the cross matches are negative, but there is a DSA, class 1 DSA against HLA A23 antigen. So there is a single class 1 DSA against HLA A23. So the issue here, obviously, is there is an HLA A23 donor-specific antibody. Cross match is negative, DSA is positive. So should you do desensitization with plasma exchange, rituximab, etc.? Yes, no, depends. Are the answers. So what I would say, if the cross match is negative, as it is here, you don't need to do desensitization. We would still put these patients through kidney sharing scheme because it's always good to transplant, give a kidney without, against which the recipient doesn't have any DSA. Their long-term outcomes are better if there is no preformed DSA against the donor. And therefore, we try that. If it doesn't work, if they don't get matching kidney, or if you can't wait, then you could go along, get along with transplanting with induction with lymphocyte depleting antibody, an ATG or alemtuzumab. Or we can go ahead with basiliximab if there is a low level DSA, as it was in this case. And we all start immunosuppression about a week before in this scenario. Which ones to start is debatable as well. We start just tacrolimus. Some centers start tacrolimus and MMF and steroids. Make up as you go along. Really, there's no hard and fast rule, but we start tacrolimus only before transplant, and MMF and prednisolone starts on the day of transplantation. Another case where these are the donor recipient HLA types, CDC cross-match negative, flow both T and B cell positive, so essentially bad case scenario, HLA incompatible transplantation, so you shouldn't do it. And when you do Luminex, a very high DSA with an MFI of 19,000. So what are the options? This is a strong DSA with positive flow cytometry and negative. Oh, was it negative CDC? for positive flow cytometry with negative CDC. So direct transplant would be unadvisable. We would put them through kidney sharing scheme and keep them on deceased donor list and hope that they will get a matching kidney against which they don't have a DSA. Or we rarely do this now. I kept it on because I know different parts of the world would go ahead depending on the scenario. If we were to go ahead, then you need to do desensitization until the cross match is negative. Just remember, once you give rituximab, it can affect the flow cytometry cross match results because the rituximab is an immunoglobulin. It will go and bind to the B cells, and your B cell cross match can be falsely positive if you've already given rituximab. So you must do a cross match before you give rituximab. That complicates the matter when rituximab is used. So please let the lab know that if you're given rituximab and you send some samples for cross match, particularly for B cell cross match, they should know that you're given rituximab. Okay, and induction can be either Campath or ATG, depending on what each center wants to. So ABO incompatibility is easy because you essentially remove the antibodies, get the titer to 1 in 16 or 1 in 8 and get along with it. Again, we don't do much ABO incompatible transplants at all now because of really successful kidney sharing scheme. For HLA, it's trickier. I mean, there are many antibodies, and what do you look for? Titers are unsure. So essentially, the target is when you do desensitization with plasmapheresis, etc. You want to achieve cross-match negativity, and you want MFI of a DSA, preferably undetectable, or at least less than 2,000 maybe. And then you need to monitor DSA levels following the transplantation. It still remains a high-risk procedure with fairly high AMR rates since we don't do it as commonly these days. This is just a quick cartoon of how our kidney sharing scheme works and how many recipients benefit from a single donor. For example, this one is a simple swap. So donor 1 gives to recipient 2, donor 2 gives to recipient 1. But then we've got more complex chains. So D1 goes to R2, then D2 to R3. D stands for donor, R stands for recipient, and D3 to R1. And then similarly here and similarly here, for example, a single altruistic donor kickstarts a chain. They give a kidney to a recipient, that recipient's donor gives to another recipient. So say you've got 1, 2 recipients benefiting or from single donor. So it's a very complex system that operates nationally and works reasonably well. This is data on another patient from a few years ago. So the line here where it is 0 is a day of the transplant. So this patient had fairly low level pre-transplant DSA against A2. And A33 is a third party HLA antibody. What I mean by third party is an HLA antibody which is not against the donor antigen. So transplanted, all going hunky-dory till day 7 with no problems, with very low levels of A3 DSA post-transplant. So all good. I'm sorry, we use micromoles per liter here. Yeah, I know everyone else uses milligram per deciliter. So around 85 or 87 micromole per liter is equivalent to, I think, about 1 milligram per deciliter. But I may be wrong here. You really need to check up. Basically, kidney doing very well with no rejection, good kidney function. And then on day 10, rise in creatinine, coinciding with significant rise in donor-specific antibodies shown in yellow circles here. And in addition, there was some rise in the irrelevant or a third-party antibody as well. Just an overall immune activation, but there was a significant rise to the titers of, or MFI, about 10,000. So we treated this patient, also had a concomitant T cell rejection along with the AMR. So we plasma exchanged and we gave ATG. Things got better, and that's the nice decline in the DSA levels following treatment of rejection, and the kidney survived, patient survived so far. Just to highlight what I was saying before, the results of HLA desensitization remain suboptimal, and KSS should remain first choice. And we must interpret DSA with all the caveats that were discussed, and we must interpret that in association with clinical picture and cross-match results in close discussions with tissue typing laboratories. And really a competent and reliable tissue typing and HLA antibody measurement and laboratory is essential. And I say it is free here, but still it comes from taxpayers' money. Eventually, we all pay for National Health Service. So we also have our budgets and costs. So it may appear as cost is not relevant as a direct coming from the pocket of the patient, but cost is still very relevant in any healthcare. And here it is for our national or NHS budget, for example. So anything we do, we just simply can't request a test just because it is free. There are very clear regulations and guidelines. For example, I can't simply do a DSA test outside a research setting just because I like to see. There are very clear guidelines. The transplant has to be across a DSA barrier, or a patient had DSA pre-transplant, or they had desensitization. Only then we monitor DSAs, otherwise we routinely don't. And we only look for DSAs if there is a graft dysfunction, in otherwise incompatible transplants I'm talking about, and if there is biopsy evidence of AMR or a vascular rejection. Okay. Because one of the issues with screening for DSA is if you start doing DSA, it costs, and if it is positive but kidney function is fine, what do you do is still unclear. You could argue those patients, you can say don't reduce immunosuppression, but should you give more immunosuppression remains unclear, and it should be driven by clinical picture, biopsy findings, and the graft function rather than just DSA test alone. And what we're trying to prevent is this: we don't want kidney shooting off operating table. Okay, so as a sort of finishing note, just wanted to make sure all these technologies are quite exciting. They give you lots of results, but you must remember most of the transplant patients, long-term or intermediate term, still die from infection, sepsis, and cardiac events. So whenever we give too much immunosuppression, we really need to think twice. Are we doing the right thing for a given patient? So please take into account the whole patient rather than an antibody test by itself when you decide what to do with them. And again, non-adherence to immunosuppression, for example, tacrolimus in particular, which is a T cell targeted immunosuppression rather than B cell. But if you look at all the literature, that's a main driver for development of DSAs post-transplantation. So people who run very low TAC levels, who don't take the tacrolimus, are the ones who tend to develop DSAs over a period of time. So if you carefully plan the transplant and keep the immunosuppression reasonable, but not too much, not too low, that's a knack, that's a clinical nuance you develop over a period of years, and make sure they take basic immunosuppression regularly, you will achieve decent outcomes in vast majority of kidney transplant recipients. I think that's all I had to say. I will stop there.
Thank you, Phanish, for that excellent lecture, and I think you made it quite easy for people. I hope because this was a lecture which the students wanted, basically, because some of these students are appearing in the final exam on 7th August.
Right. Okay.
So they just wanted to refresh their immunological evaluation. This is something which, especially with the new Luminex single antigen beads, now they get sometimes confused. And when they are given the data, then interpretation becomes somewhat difficult. And I feel that with your lecture, I'm sure they would feel more confident of maybe interpreting the data as well. And you emphasize very elegantly that don't depend on the single test. It's the overall milieu in which you are doing the transplant and in which you see the patient, is take patients into clinical history into account and then interpret the test in accordance with that patient. And that's what clinical medicine teaches us, that don't, whatever test one is talking about, tests have to be interpreted in accordance to the kind of patient that you're seeing. And they should always be done so. And if you do so, then you will be making wiser decisions rather than, and where you don't have to repent. But otherwise, if you interpret only the test and just want to take a decision just based on the test, then you are likely to make a wrong decision. And I think that's very, very well illustrated, as well as you made it very, very emphatic that please
Thank you.
do not interpret tests in isolation. And I think that's very true. I have one question. A patient I had, you may have seen that patient, I don't know, Fiona. This was a Kenyan girl whom we had transplanted. First transplant done in 2010. Father gave the kidney.
Yeah.
She went back to Kenya. I did see her once in Mombasa when I was visiting her. She was doing okay till then, but I think she started as she grew up. She was about 10 years old at that period of time when we first transplanted, maybe even younger, 9 years. And then as she grew up, non-adherence came into the picture, and I think she started missing her drugs, and she lost this graft last year. 2019, she came back to us. So this graft was about 10 years. It did function. Then we put her on dialysis, and we're looking for second transplant for her. And then we didn't look at the paternal. She had some anti-HLA antibodies. At that point of time, we didn't know who will be the donors. So we looked at some of the donors, predominantly from the maternal side, because she had received the kidney from the paternal side. And you had made it quite clear that if you have anti-HLA antibodies, then memory of the first kidney transplant will usually tell you as to what kind of antibodies this patient would have. So anyway, we found two maternal aunts. We couldn't, because there was strong cross-match positivity with flow cytometric cross-match, so we disregarded these maternal aunts. And then we were struggling to find a donor when there was another Kenyan who was in the hospital, and who, after talking to the father, said that if she would be very keen to donate a kidney to her if the Medanta committee agreed. And so we went to the committee again, and then the committee agreed that, okay, this was a kind of an altruistic donation, which happened not in true sense, but this was this became a directed kind of an altruistic donation to this girl. And we found that there was one HLA antibody, which was to DQ. It was about 10,000,
Okay.
which was a donor-specific antibody. But the flow cytometric cross-match and the CDC cross-match was negative.
Okay.
I tested it twice.
Yeah.
And I found that the flow cytometric cross-match, both at our place as well as at the another lab, was again negative. This donor-specific antibody was against just one antibody against this donor-specific antibody. So it was about 10,000. Since the flow cytometric cross-match was negative, we went ahead and did a transplant without any desensitization with ATG induction.
Yeah.
And she did extremely well, except that she developed anemia once, which was again related to the parvovirus. And we gave her IVIG, and her hemoglobin got better and reduced the immunosuppression for some period of time, except for another UTI. Otherwise, she remained and did very well. It's about 1.5 years now. So this was about 10,000. I was worried, and I had discussed this with the father that this patient might still, although how would you explain this flow cytometric cross-match negativity in this patient?
Yeah, that's a tricky one, and it seems to happen with DQ a bit more than, say, for example, DR.
Yeah.
For example, if this antibody levels with the DR antibody, without doubt, that flow cytometric cross-match would be positive. For some reason, it seems to happen. I don't think I know the answer correctly as to why that may be, but certainly an immunologist, I'm more a practicing clinician with some basic science, may tell more. But I have seen this with DQ antibody. That's number one. It may simply be so. it's a binding ability. It may be one of those antibodies which has a weak antigen binding ability. Because when we look at the cross match, we make an assumption that every HL antibody binds to its HL antigen with equal affinity. And that premise is not true, because they do bind with differing affinities. And that's one of the issue with Luminex as well. For example, we say MFI of this, MFI of that, but high MFI may be simply because it binds higher for the particular antigen rather than more antibodies. So same amount of antibodies, but one binds more than the other. So
Yeah,
it may well be that DQ antigen antibody binding is low, and therefore it just doesn't bind in a cell. And therefore as well, the outcomes are fine because it's not going to bind and cause complement activation.
yeah,
Um,
I understand. I tried to look at the literature again, got few references that DQ binding may not be good. That's why the
hmm,
flow
hmm,
cytometric cross matches
hmm.
is not positive. But the question is, it keeps on worrying you till you do the transplant.
Indeed, and indeed,
And the
indeed.
question was that whether one should go ahead without doing any desensitization, or since the cross matches were negative, I wasn't very sure how would I say
How would you
desensitization
justify?
was enough, was
No,
enough.
absolutely, absolutely. As I say, I think it's a right thing not to do desensitization when the flow cross match is negative. I wouldn't say it's a right thing to do if only CDC was negative,
Yeah.
because it's not sensitive enough. But if flow is negative, it's fair enough to say, look, you have DSA, but it's not binding your cells. And flow cytometry is very sensitive by all means. And therefore, I think it's right to go ahead with ATG and triple immunosuppression long term, but
Yeah.
they are still at a higher risk of chronic AMR
Yeah, that's
and
true.
transplant glomerulopathy, proteinuria, etc. So that
I
issue
have,
remains.
yes, I repeated the DSS
Yeah, it would have gone
in
down.
they don't know 1 year. Yeah, it's gone down.
It
It's
would have gone down.
significantly gone down.
It
It's
does.
significantly gone down.
It does. Once you give mycophenolate and ATG, it goes down. So as
Yeah,
long as she keeps her TAC levels between
yeah,
5 and 8, as long as the tacrolimus level is maintained above 5, and she keeps taking TAC MMF pred long term, the DSA goes down and stays down. Only problem will come if the adherence issue comes and the TAC level starts dropping.
yes, yes.
And then again, she will develop, the DSA titer will go up, then you will get transplant glomerulopathy or a chronic AMR, proteinuria, graft dysfunction. So I think that's the right thing to do, to have a clarity. If the cross match is flow cytometry cross match is negative, it's hard to justify desensitization because you really don't know what you are trying to achieve
Yes.
by doing all the extra measures. And what we do is, if that happens, you basically warn them, look, you may still get an AMR. If that happens, we have to do plasma exchange. And if there is bad vascular rejection, we have to give you more ATG, etc.
Yeah,
But
yeah,
it's the
yeah.
right thing to go ahead without, as you
Yeah,
did.
I think your education helped in making my decision in this
I think
patient.
that's an overstatement. Yeah.
No, I think no. Phanish, your coming during those days was definitely very, very useful to us. It
Thank
widened
you.
and opened the horizon of our discussions
Great.
during
Thank you
that
very
period,
much.
and I think
That's the
that
whole idea.
was very helpful.
Yeah.
I don't know if there are any questions. I don't see any questions on the chat box. Anyone wants to raise a hand, or I think if not, then I would say thank you. Thank you, Phanish, for
Thank
that.
you.
Wonderful, wonderful. It was a pleasure to have you again, and I'm sure that we might utilize. I hope you will agree in future as well to maybe come in and help.
Definitely. Definitely.
We
It's a
do
pleasure.
this regularly for our DNB students across the
Yeah.
NCR,
Okay. Yeah.
and we do hope that I know it consumes your time as well as effort, but then this is the price. We will take back something that
Absolutely. No.
you had with us. So I hope you
Oh,
don't
no, it's fine.
mind that. Thank you very much. Thank
I
you
will do
very
it
much.
if I can. Yeah.
Yes. Thank you very much,
Thank
and give my regards to your family, and thank you. Thank you for agreeing.
Thank you.
And
Thanks for inviting.
and
Thank you.
bye-bye, everybody.
thank you, sir. Thank you, Dr. K. And a
Okay.
special thank you,
Okay.
Dr. Phanish, sir. Thank you.
Thank you.
Okay.
Thanks for organizing.
Sir,
Okay.
can we share the
Okay.
recording with the students, sir?
Yes.
Say
Can
that
we
again?
share the recording? Can we share
Yes,
the
you can.
recording with the students?
Yeah. I was just going through quickly to say there was any patient identifiable information. I don't think there is any.
No, there isn't. There isn't.
So yeah, it's fine. Yeah, it's fine.
Okay, sir. Thank you, sir. Thank
Thank
you
you.
so much.
Okay.
Thank you.
Thank
Okay.
you.
Bye-bye.
Thank you.